Thank you for the whole White Army team. So I was extremely glad when Dr. Kishan called me for to deliver a lecture on this platform, because I have given so many talks on various platforms, including the Physicians Forum, Endocrinologist Forum, Orthopedics, Gynec, but I have never ventured into this White Army till now. So I was very happy when Kishan called. I said immediately yes. So for the next probably 45 minutes or so, I'll try to discuss regarding the various thyroid disorders, how to approach that. And initially, I'll discuss a few things regarding physiology, then hypothyroidism, and then hyperthyroidism. These are the most commonly encountered problems, hypothyroidism and hyperthyroidism. In addition to that, there are euthyroid goiters, nodular goiter, solitary thyroid nodule, multinodular goiters. So I'll not go into that in detail today. So I'll discuss functional problems of thyroid gland, that is hypothyroidism and hyperthyroidism. So I'll just discuss briefly regarding the physiology. So all of you are well aware that the thyroid gland is under the control of pituitary gland, which is in turn under the control of hypothalamus. So it's a famous feedback mechanism, negative feedback mechanism. That means whenever the thyroxine level comes down, or whenever the triiodothyronine level comes down, immediately the signal will go to the hypothalamus, and from there the more and more TRH will be released. TRH is nothing but thyrotropin releasing hormone. This thyrotropin releasing hormone in turn will increase the level of TSH, which will stimulate the thyroid gland to produce more and more hormones. This is the classical negative feedback mechanism, which is there in almost all the endocrine glands. For example, in case of adrenal, whenever the cortisol comes down, the ACTH will go up, which will in turn try to stimulate the adrenal gland to produce more and more cortisol. Similarly, most of the endocrine glands are under the control of negative feedback inhibition. So then one can ask, what is the example for positive feedback mechanism? So very few positive feedback mechanisms are there in the body. So one is the LH surge, which happens just before ovulation in case of women. And one more is that also the positive feedback mechanisms are seen only in women. I don't know what is the reason for that. So the second example is oxytocin surge, which happens during the delivery. And third is prolactin secretion during the lactation. So these are the examples for positive feedback mechanisms. But most of the endocrine glands are under the negative feedback control with the help of hypothalamus and pituitary. So the most important part of this loop mechanism, feedback loop mechanism, is to maintain the physiology. So whenever there is some decrease in the hormone levels, immediately because of this negative feedback mechanism, the stimulating hormones will increase. That in turn tries to maintain the thyroid hormone levels in the blood. So TSH, when in turn will stimulate the thyroid gland. Here we can see the thyroid follicle, the basic structure of thyroid gland. This thyroid follicle is responsible for the production of thyroxine, and thyroxine in turn will get converted into triiodothyronine. So how does exactly this synthesis happen? So we know that iodine is one of the major ingredient for the production of thyroxine. So the iodine, whichever we consume in the food, so iodine will be selectively taken up by the thyroid gland. So there is something called as selective absorption from the thyroid gland. So the whatever iodine we consume mainly goes to the thyroid gland. Even if there is something amiodarone, what is given as the medication, out of that 39% of amiodarone is iodine. So that also goes specifically to thyroid gland. So that is the reason the people who are taking amiodarone, we have to check regularly for thyroid dysfunction, because excess iodine can also be harmful to the thyroid gland. So it can produce both hypothyroidism as well as hyperthyroidism. So what happens when the iodine will be imported to the thyroid follicle, and there it will be oxidized. So the first step is iodine oxidation. So it becomes iodide oxide. So the I minus we can see here. So once the iodine, here we can see it. So in the thyroglobulin, so within the follicle, there will be thyroglobulin protein. So in that, so the iodine, once it's oxidized, then it becomes active. So the oxidized iodine will combine with the amino acid called tyrosine. So this tyrosine and iodide combine to form monoiodotyrosine. So one molecule of iodine will combine with tyrosine to form monoiodotyrosine, and two molecules of monoiodotyrosine can combine to form diiodotyrosine, or two iodine molecules themselves can combine with tyrosine to form diiodotyrosine. If two diiodotyrosine merge, the process is called coupling. So the oxidation of iodine is called, after oxidized iodine combining to tyrosine, it's considered as organification. The name is given as organification. Then two diiodotyrosines combining to form thyroxine, it's called coupling reaction. So, and one diiodotyrosine plus one monoiodotyrosine, if it clubs, it forms triiodothyronine, or three molecules of iodine, it's called triiodothyronine. So out of the total synthesis, 90% is thyroxine. Out of the thyroid hormones which are produced within the thyroid gland, 90% is thyroxine, and only 10% is T3 or triiodothyronine. But we know majority of the actions of thyroid hormones in the body or at the receptor level is mainly due to T3. So, but whatever T4 is produced in the periphery, in the circulation, T4 will be converted into T3 by an enzyme called as deiodinase. We can see here this is a schematic table. We can see in this various steps of thyroid hormone synthesis: iodine uptake, then oxidation of iodine, then oxidized iodine combines with the tyrosine. It's called organification. So to form monoiodotyrosine and diiodotyrosine, coupling leads to production of thyroxine and triiodothyronine. So this thyroid peroxidase is an enzyme which catalyzes the coupling reaction. And then once it is formed, it is released into the circulation. Both T4 and T3 are released into the circulation. In circulation, once it is secreted from the thyroid gland in the blood, it is usually transported by binding protein. It is transported by the binding protein, thyroxine binding globulin. Please unmute. Please mute yourself. So, in actually thyroxine in the blood, it binds to the binding proteins. Most commonly, thyroxine binding globulin. Then albumin, because albumin is in abundance, so it binds to albumin also. And one more protein called as transthyretin or prealbumin. These are the three binding proteins with the help of which the thyroxine moves freely in the blood. So in addition to that, small subset of hormone is also circulates. Around 0.5% of the total hormone circulates in the free form also. That is called free thyroxine. In fact, most of the actions are due to free hormones, both free T4 and free T3, which is not bound to these binding proteins, are responsible for the majority of action, but the concentration of which is very, very tiny. The total 0.5% of the total hormones. So this is the last step. The 5-deiodinase enzyme converts T4 to T3. And some of the inhibitors of these enzymes, deiodinase inhibitors, beta blockers, propylthiouracil, and glucocorticoids. These are helpful when we are dealing a patient with thyroid storm, because as I already told you, the majority of the hormones action, thyroid hormones action, is due to T3. So if we block the conversion of T4 to T3, so majority of the actions can be prevented. So maybe it on the heart, maybe it on the intestine, on various parts of the body, the action can be prevented if you can prevent the conversion of T4 to T3. That's how, in case of thyroid storm, or when there is a crisis, we can use glucocorticoids, beta blockers to prevent this blockade. Propylthiouracil in large dosage, when we give it in the 600 milligram per day dosage, in very large dosage, it can inhibit the conversion. So this is in nutshell regarding thyroid hormone synthesis. Now, see, I'm not very well versed with the physiology. Only this much I can tell you, because I am a clinician. So what I'm interested in, how to investigate, how to evaluate a patient with thyroid dysfunction. So the first question, which one should be selected? Among the thyroid function tests, we have T3, T4, TSH, free T3, free T4, and rarely we can ask for reverse T3 or reverse T4 also. So which one should be selected out of these? So one simple answer, most useful test of thyroid function is TSH. So itself, actually, we know that the hypothalamo-pituitary thyroid axis, the stabilization, it takes time. So the whenever we are dealing with a patient, if we start a treatment also, the normalization of TSH, even both in hyper and hypothyroidism, it takes at least 6 to 8 weeks. So, but one thing we have to remember, the first thing to go abnormal in any pathology, both in hyperthyroidism as well as hypothyroidism, is TSH. One more very important point we have to remember is there is inverse logarithmic relationship between TSH and T4. Even if there is a minor variation in T4, let us say the T4, it was a normal physiologically, a person named A, his T4 is 8 microgram per deciliter. It drops down to 7.5 or 7. So it is normal. If you do the T4 level in the blood, it will be shown as normal only. But for that particular person, his normal level was 8 microgram per deciliter previously. So there was a drop from 8 to 7. So there will be significant increase in TSH because of the inverse logarithmic relation. There will be significant increase in TSH because of this drop. So that is the reason T3, T4 might look like normal, but TSH will be elevated in many patients. So whatever we see, the T4 of 6 or 5.5 or 7 might look, if we look into the normal reference range, it might look like normal, but it is low for that particular person because previously his T4 would have been high. So that is the reason most important test, which if you can ask a single test to be collected, then it is TSH. So now the next question, if we use only TSH, will we miss something? Because we should not miss any pathological entity if you are asking for a test. You do thyroid function as TSH and it comes normal, then you should not miss other entities like any major problems. So majority of the functional derangements, primary hypothyroidism, thyrotoxicosis, or euthyroid state, they can be identified correctly with the help of TSH. But what can be missed is central hypothyroidism. Why we can miss central hypothyroidism? The reason is simple. In case of central hypothyroidism, the TSH might be normal. So what goes down is T4 or free T4. Why does this happen? Because in central hypothyroidism, or whenever there is a pituitary cause of hypothyroidism, so there can be lowering of free T4, but TSH can be measured as normal because it is bioinactive but immunologically reactive. So when there is immunologically reactive but bioinactive TSH, it will not stimulate the thyroid gland, but it will be measured as normal TSH when we are doing assay through chemiluminescence or radioimmunoassay. So now the next question, shall we go for total hormone assessment or free hormone assessment? So for all practical purposes, total hormone assessment is good enough. The reason is, as I already told you, the total hormone levels. Total means it measures free hormones plus bound the hormones. It measures the total hormone levels in the blood. So the level of the hormone levels is much higher compared to free hormones. As I already mentioned, it is only 0.5% of the total. Free hormones, the level is only 0.5% of the total. So the level in the blood is much lower. Whenever analytes concentration is very low in the blood, the assay becomes more and more difficult. Let us say a hormone is there in the blood in the concentration of picogram per ml. It's very low level. So the detecting that picogram per ml quantity of hormone becomes difficult. The same thing with free hormones. It is in nanogram per deciliter. Most of the free T4 is in nanogram per deciliter and free T3 in picogram per ml. Picogram, you know, is 10 to the power minus 12. So when the hormone is in such a low quantity, the assay becomes difficult and it is more prone for errors. Just 1 minute. So when the analytes concentration is very low, it is the assay becomes more and more difficult and the errors are more. So that is the reason it's better to go for total hormone assessment rather than free hormone assessment. So, but when we are expecting binding protein related abnormalities, like the patients with nephrotic syndrome, cirrhosis, or patients who are using oral contraceptives, there in nephrotic syndrome, because of the hypoalbuminemia, the binding proteins are low. So that is the reason total hormone levels can come low. In cirrhosis, it will be like that. And in case of oral contraceptive pills usage, because of the excess estrogen, there can be increase in the TBG. So all these conditions, it is better to go for free hormone assessment. So pregnancy, oral contraceptive pills, liver or kidney failure, these are the conditions in which we should go for free hormone assessment rather than total hormone assessment. Otherwise, the total hormone levels are better. So because of the problems in the assay. So to summarize regarding the blood test to be asked, under steady state, TSH is the single most useful screening diagnostic test. So, but if you don't want to miss any other like central hypothyroidism, pituitary causes, then it is better to ask for T4 also. So TSH and T4, if you ask, majority of the functional derangements of hypothyroid, functional derangements of thyroid can be detected. Then the next question will come, why not T3? Why I am asking only for T4? This is a practical issue. Once again, the T3 concentration is very less. Once again, it's in nanogram per deciliter. Compared to T4, the T3 levels are less in the blood. And one more, most of the chemiluminescence assay machines which we use in practice, in clinical practice, the T3 assay requires daily calibration. So the daily calibration becomes all the more difficult. So that is the reason the most of the T3 assays are prone for errors. So that is the reason whenever you get a T3, abnormal T3 with normal T4 and TSH, you have to always take it with a pinch of salt. So that's why I told you, with all practical issues, TSH and T4 will be enough. T3 or free hormones are not required. Only in specialized situations when you are expecting T3 toxicosis or multinodular goiter with the normal T4 suppressed TSH, in such cases, you can ask for T3 also. Otherwise, T4 and TSH is enough. Next, I will go into the functional derangements. The first I will discuss regarding hypothyroidism. So I will start with the case scenario. 29-year-old lady, severe tingling and numbness of both upper limbs, especially hands. She has a severe tingling. So she went to a neurologist. The nerve conduction study was done, which showed carpal tunnel syndrome. So both hands, carpal tunnel syndrome was there. She has while asking, she has a constipation, weight gain, menorrhagia, and hair loss. Those symptoms were there. So, but the symptoms were severe, so she was advised release surgery. But once the thyroid function was asked, it was very clear. All the symptoms were attributable to hypothyroidism. You can see here, T3 normal 72, T4 6.5, TSH of 45.3. So just now I was telling you, so the T4, T3 can be normal and TSH can be high. So this is the most common biochemical investigation reports what we get. Low T3, T4 happens very late, and by that time TSH will be more than 100, majority of the times. So this is because the TSH in a higher quantity will stimulate the thyroid gland more and more to produce the whatever remaining thyroid follicles, the undestroyed thyroid follicles will secrete a little bit of hormones. That's how the TSH is high and T3, T4 are normal. So this lady, because of primary hypothyroidism, the TSH high, normal T3, T4, primary hypothyroidism, she had all the symptoms, various symptoms, generalized symptoms, as well as carpal tunnel syndrome symptoms. So in such patients, usually surgeries are not required, because once you start thyroxine, the accumulation of glycosaminoglycans or mucopolysaccharides which are happening in the carpal tunnel, they will slowly reduce in quantity, and ultimately the compression will go, and they will not require any surgery. So that was very, very clear-cut case actually. So we will not get such clear-cut patients in our OPDs. So the main reason is our patients do not read Harrison and come. Like us, they don't read Harrison. So that is the reason symptoms are mostly atypical in majority of the patients. So when do we ask for thyroid hormones then? So we have to screen for thyroid dysfunction in at-risk population majority of the times, like past history of autoimmune thyroid disease, people who had a thyroiditis or a history of thyroid dysfunction in the past, so and they have stopped medication of some time. If they had history of anti-TPO antibody positivity in the past, anti-TPO antibodies is nothing but the thyroperoxidase antibodies against thyroperoxidase, so which is responsible for thyroxine synthesis. So antibodies will impair the thyroxine synthesis. So that is the reason. So anti-TPO antibody, if it is positive, very likely that the patients will go into hypothyroidism in the future. The past history of radioiodine therapy, radioactive iodine therapy, if they have taken, so then also we have to ask for thyroid hormone levels, and history of head and neck irradiation for various tumors of the head and neck area. So then also the thyroid gland can affected and can go into permanent hypothyroidism. So family history of autoimmune thyroid disease, if the family, the parents, one of the parents or siblings or the paternal or maternal relatives, if they are having autoimmune thyroid disease, even if the slightest suspicion is there, if some symptoms are there, it is better to ask for thyroid hormone levels, especially the TSH. Then the endemic areas like iodine deficiency area, then we have to ask for TSH. And drug exposure like amiodarone, lithium, interferons, and some of the newer anti-cancer agents, such patients, if the such drugs, if the patients are taking, better to ask for TSH. So what are the symptoms? So symptoms, actually, most of the hypothyroidism symptoms are non-specific. The constitutional symptoms, from head to toe, all the organs are affected in hypothyroidism. So that is the reason. So it's very difficult to identify only by symptoms, and sometimes high index of suspicion is required. So that is one of the problem related to hormones. We know hormones are nothing but the secretions from the endocrine glands, which are secreted into the bloodstream. So the effects can be seen anywhere. Whereas exocrine glands, which are mainly seen in the gastrointestinal system, so it is through the ducts, it is secreted into the intestine. So that is the reason the symptoms will be related to gut only. If there is any problem related to the heart, it will be in the chest only, because the majority of the symptoms happen to heart will be observed in the chest. But in case of endocrine problems like hypothyroidism or any other endocrine problem, the symptoms will be generalized. It will be everywhere. So it's very difficult to go only by symptoms. So these are the various symptoms. We can go through the slide. You can just see the slide. Weakness, then lethargy, loss of hair, then weight gain, slow speech, slurring of speech, then alteration in voice because of the accumulation of glycosamine and glycans in the vocal cord area, and thick tongue, cold intolerance, sensation of cold, pedal edema, not only pedal edema, facial puffiness, the edema of the whole body, then dyspnea, then anorexia, deafness, memory impairment, constipation, then menorrhagia, then amenorrhea, infertility, then paresthesias of the extremities, almost muscle weakness, muscle difficulty in getting up from sitting, almost all the symptoms you can name from head to toe, or any symptom that can be attributed to hypothyroidism. But most important thing, whenever a patient comes and sits in front of you, most important thing you have to observe is his neck. Any symptoms of this kind, if it is present, or if you are not able to explain by one particular organ system, then always look at his neck. So in at least 30 to 40% of the individuals with these symptoms, if there is a goiter, then you can definitely think and tell that there is some thyroid related issues. So if the patient is having generalized non-specific symptoms and there is a goiter, then always ask for thyroid function. Coming to the signs, bradycardia, then dry skin, puffiness of face, presence of goiter, non-pitting edema, slow speech, and finally the delayed relaxation of deep tendon reflexes. These are all the various signs. Once again, I will tell you the most important thing among these is goiter. So very easy to see, and the majority of the goiters are visible. So goiter also can be graded. So which is like grade 0, it's a WHO classification. Grade 0 is no goiter. Grade 1, just palpable. It's not visible, but when you examine, when you palpate, there is a goiter. It's called grade 1 goiter. Then grade 2, it's not only palpable, it's visible also. So when you ask the patient to swallow, then when swallowing, the thyroid moves up with deglutition. So that's called that's grade 1 goiter. And grade 2 goiter is visible. Grade 3 goiter is visible from the distance. So whenever the patient enters to your room only, you can see the goiter. That is called grade 3 goiter. So the presence of goiter and all these symptoms, if they are present, then you have to ask for thyroid function. Even if the symptoms are not there, if the patient is having goiter, it's always better to ask for thyroid function, especially TSH. So in addition to these typical manifestations, the patients can have atypical manifestations like depression. They can present only with infertility. Infertility, there is a dictum telling that any patient comes with infertility, the first hormone to be tested is TSH. Before going for ultrasound or anything, first thing to be done by any infertility specialist is asking for TSH. If the TSH is high, then immediately the infertility specialist or endocrinologist will start treatment so that there will be a better, significant betterment in ovulation, and fertility results are much better. Other atypical manifestations are precocious puberty. So this is also very atypical presentation. The patients can present with the large cysts in the ovary and precocious puberty, and in boys that can present as macroorchidism. So the macroorchidism, or if the patients, if the child or girl presents with the premature menarche without breast development, then we have to always ask for TSH or thyroid function. Then pericardial effusion, pituitary adenoma. So how does this pituitary adenoma happen? Pituitary adenoma, it's mainly because of the stimulation by the TRH. So the large, if the T4 becomes low and it goes on for a long period of time, the TSH, when you see if it is more than 100, if you do MRI, majority of the people will be having homogeneous enlargement of the pituitary gland, or it's called thyrotroph adenoma. So once you start thyroxine, usually these pituitary adenomas will disappear. At times, rarely, it's not common. When the patients go for evaluation of headache, they do MRI and they find that large pituitary adenoma. So if at that time, it's always we have to investigate for the pituitary function, including thyroid function, because otherwise, by mistakenly or by without knowingly, the patients with the large thyrotroph adenoma can undergo pituitary surgery as also. It has happened in the past. So without doing thyroid function, without documenting normal thyroid function, no pituitary surgery should be performed. Coming to the next aspect, subclinical hypothyroidism. So what is subclinical hypothyroidism? It's actually a misnomer. It is not subclinical hypothyroidism. Here, clinical symptoms may or may not be present. Here, it's actually biochemical abnormality. So here, the normal T3 and T4 will be normal, and TSH will be increased. So just now I have told you, in that case, the TSH was very high, 45 in our index patient, whatever I have shown, but sometimes it can be below 10. The T3, T4 normal, but TSH in between 5 to 10. So that condition we can consider as subclinical hypothyroidism. So the progression to frank hypothyroidism happens in many patients, but not all. So subclinical hypothyroidism, the presence of subclinical hypothyroidism, we need not treat immediately. Only in patients with the indications we have to treat. So in patients without goiter, no goiter, or if the anti-DPO antibody is negative or other risk factors are not present, then we can just observe the patients and ask them to repeat TSH after 6 months in case of subclinical hypothyroidism. Then the question comes, when to treat? So these are the indications for treating subclinical hypothyroidism. The TSH between 5 to 10 with normal T3, T4. If the patients are having any of these, presence of significant dyslipidemia, cholesterol levels being very high, it can be due to hypothyroidism itself. The presence of large goiter, the positive anti-DPO antibody. Then if the patient is pregnant, between 4 to 10, if the patient is pregnant, definitely it's better to treat. Or the TSH more than 10, if the TSH is more than 10 in subclinical hypothyroidism, it's better to treat. And infertility, definitely infertility we have to treat, because even between subclinical hypothyroidism, when it is treated, many literature, many evidences, many like journals have clearly shown that TSH between 5 to 10, if you treat, there is significant improvement in fertility. So these are subtle indications: neuropsychiatric manifestations, carpal tunnel syndrome, unexplained hyponatremia, short stature, pubertal problems. All these we can think of treating. So one thing here, hyponatremia. So hypothyroidism is one of the major cause for hyponatremia. So whenever a patient has hyponatremia without any reason, so let us say the patient got admitted with hyponatremia, there is obvious reason like the patient was on diuretic, then we need not ask for thyroid function. But if there is no obvious cause for hyponatremia, it's always better to ask for thyroid function and even adrenal insufficiency, because so any textbook or any journal, if you go through, they clearly say that these are the two tests are mandatory before branding the patient as having SIADH, which is a common cause of hyponatremia. So thyroid function and cortisol are a must before terming the patient as having SIADH. Coming to the treatment aspect of hypothyroidism, it's very simple actually. So here the hormone is missing, we have to replace it, that's all. So replacing the missing hormone. So thyroxine is the hormone which is missing. So L-thyroxine is a preparation of choice. Then you might ask, why not T3? The T3, so the what L-thyroxine, whenever we give, it will be converted to T3 in the periphery. So that is the reason the T3 preparations are not easily available. So only in special situations when we want immediate result, like the patient's TSH levels are very high, or if the patient is planning for iodine therapy, iodine 131 whole body therapy, like in after post carcinoma surgeries. So in such situations, we can think of T3, which is not easily available. Only in some centers it is available in India. So otherwise, the usual routine prescription is L-thyroxine, levothyroxine. What is the dosage? Usual dosage is 100 microgram per square meter. So 100 microgram per square meter, or in adults, it is 1.6 microgram per kg body weight. But mind you, this 1.6 microgram per kg body weight is the dosage for adults with overt hypothyroidism. Like if the TSH is more than 20, or the patient is having obvious symptoms and large goiter, then this is the requirement. But if the patient is having TSH of 10, 12, 13, 15, in such scenarios, we need not start with this full dose. We can start with a lower dosage like 25 micrograms or 50 micrograms also. T4, we know it has a very long half-life, 6 days of half-life. So once daily dosage is enough. So bioavailability changes from brand to brand. So that is the reason in particular patient, it's better to stick to one particular brand rather than changing the brand every time the patient visits. So better to stick to one particular brand because it's in microgram quantity. So most of the medications what we give in our routine practice is in milligrams or grams. So you take any preparation, they are in milligrams or grams. So thyroxine is in microgram. So the purification of the medication or the product, the consistency of the product is very, very important. So that is the reason it's better to stick to one particular brand rather than changing it. So T3 is not indicated for chronic management, only in acute management, just like I mentioned. So in such cases, we can go for T3. Crude thyroid extract, previously which was commonly given, abexide or other amino acids are not recommended, and they no longer advocated in the management of hypothyroidism, and it should not be given. Because why it should not be given? The crude thyroid extract, previously it was coming as abexide. Now also I think it is available, but we don't know how much thyroxine it contains. So it's very difficult to titrate the dosage. So that is the reason it should be avoided as much as possible. So the determinants of thyroxine requirement are age of the patient. So in congenital hypothyroidism, whenever we diagnose congenital hypothyroidism, we have to start immediately because the neuronal maturation and the brain development definitely requires thyroxine. So that is the reason. So most of the centers have made neonatal screening is compulsory for congenital hypothyroidism. So the requirement is higher. Whenever in a neonatal or congenital juvenile hypothyroidism, the requirement is higher. So as soon as the child is born, so the requirement is approximately 15 microgram per kg. So just now I was telling you 1.6 microgram per kg is the adult requirement. Here in a neonate, the requirement is 15 microgram per kg. And as the age advances, so the requirement comes down. Like then after probably 6 months, it becomes 10 microgram per kg. Then in the juvenile, 6 microgram per kg, then 4 microgram per kg. In the adolescence, it becomes around 2 microgram per kg. So in pregnancy, the requirement is higher. So again, it's approximately 2.4 microgram per kg. So that's how the age of the patient and the like pregnancy or postpartum also is very important. And duration and severity of the hypothyroid state If there is just diagnosed the TSH is only 10 or 15, we need not start with the full dose. We can start with 50 micrograms. And one more important thing is underlying cardiac disease. If any cardiac disease, if the patient is having ischemic heart disease, or if the patient had myocardial infarction recently or awaiting bypass, so such patients, we should not start with a full dose. So better to start with a low dose and slowly build up the dose, because we know the thyroxine is in a hormone which will increase the myocardial oxygen demand. So the metabolism will increase. As soon as you start thyroxine or give thyroxine, the patient is hypothyroid for a long period of time, so the metabolism will be much lesser. So once you give thyroxine, the body metabolism will increase, so even the myocardial oxygen demand will increase. So that can precipitate ischemia. So that is the reason in underlying cardiac disease, patients with underlying cardiac disease, it's better to start with a low dose. And other things like concomitant drug therapy, if the patients are on glucocorticoids or anti-epileptics, so the enzyme-inducing drugs, then the requirement might increase. Then in healthy young patients, it's always better to start the full dose, especially if the TSH is more than 20. And long-standing disease, elderly or IHD, as I was just mentioning, to start with a small dose with 25 microgram per day, and we can increase the dose by 25 microgram per day every 4 weeks. So these are the drug interactions for thyroxine. The phenobarbital, phenytoin, and rifampicin, they accelerate the metabolism of thyroxine. So that is the reason requirement will be more. The thyroxine requirement will be more in such patients. And some antacids like sucralfate, aluminum hydroxide, they will inhibit the absorption of levothyroxine from the gut. And even the ferrous gluconate or even calcium preparation will reduce the thyroxine absorption. So that is the reason it's always better to space out the thyroxine as well as calcium and iron preparation. This is very important in pregnancy, because in most of the pregnant women will be on calcium and iron supplementation. So it's always better to give a gap of at least 4 hours between thyroxine and calcium or iron preparation. So the monitoring is mainly based on TSH only. So TSH usually to be asked for after 8 to 12 weeks after the start of treatment. So as I mentioned in my initial slide, the stabilization of the hypothalamo-pituitary thyroid axis takes time. So that is the reason if you ask within 4 weeks, immediately after starting, within 4 weeks, if you ask for TSH, the TSH will be still high. And what will you do? You will increase the dose of thyroxine, thinking that the dosage is not enough. But we should remember that it takes time. At least 8 weeks are required. So we should not ask for TSH before 8 weeks of treatment. So T4, normalization of T4 can happen much earlier. So the steady state T4 can be achieved even at 4 weeks of time. Up to, by 6 weeks, definitely it will be achieved. So suppose if the patient is awaiting surgery, so let us say the patient is to be planned for another surgery in next, ideally planning for surgery immediately, but not an emergency surgery, elective surgery. So at least after 1 month, if you want to do, the TSH was more than 100 initially, don't ask for TSH after 4 weeks. You ask for T4 or free T4. If the T4 is normal, then the fitness can be given for surgery, because ultimately what decides various metabolic functions of the body is not T4 only. It's not TSH. So that is the reason if the T4 is normalized, we can give fitness for surgery. Once the TSH is stable, then if the patient is compliant, if the patient is taking regularly, no symptoms, then we can monitor once in a year. So that's more than enough. So hypothyroidism patients who are taking regularly, so then once in a year monitoring is more than enough. So failure to respond to thyroxine or requirement of very large dose of thyroxine, unless they are enzyme-inducing drugs or other drugs, whatever I have mentioned, is very rare. And then the first thing we have to suspect is compliance. The patients might tell that they are taking regularly, but they might not be taking it. That we have to ensure that the compliance is good. Next question, majority of our patients will be asking, or even you will be curious, whether hypothyroidism is permanent. Is there any chance that the hypothyroidism can be transient? Yes, the hypothyroidism can be transient. So following thyroiditis, like various causes of thyroiditis, like postpartum thyroiditis, decurrence or subacute thyroiditis or granulomatous thyroiditis. After that, so initially during this phase of thyroiditis, the TSH will be suppressed and T3, T4 will be on the higher side. But we know the thyroid gland has storage hormones for the next 3 to 4 weeks. That much of storage hormone will be there in the gland, within the gland. So, but during the thyroiditis phase, because of the inflammation, so whatever the hormone, stored hormone in the gland will be suddenly released into the circulation. So, sudden burst of T4 and T3 into the circulation. So, that leads to increase in T4 and T3 and suppressed TSH. This is what we call it as thyroiditis. So, after once the thyroiditis acute phase subsides, when the patients are recovering, so there is no storage hormone left. The thyroid is yet to start its function again. So in that case, the T4 level will drop. T4 level will drop because half-life, as I mentioned, it's 6 days. The T4 levels will drop and T3 levels also will drop, and that is the reason TSH will go up because of the negative feedback mechanism. And by that time, by 1 month or 1.5 months, the TSH will go up to 2 months. TSH will go up. So this phase, if we catch the patients, if we do the blood test during this phase, then the TSH will come as high, 10, 15, or even up, it can go up to 20 also. So after some time, it's just like a cradle going that side and coming back to the original position. So then because of the stimulation by the TSH and the thyroid gland started its function again, recovered thyroid gland, so then it will start secreting thyroid hormones again. So it will become normal. So that is the reason postpartum thyroiditis and decurrence thyroiditis, the hypothyroidism can be transient. And drug-induced causes like amiodarone, lithium, interferons, if we stop these drugs, insulting drugs, then definitely offending drugs, if we stop, the hypothyroidism can be reversed. So hypothyroidism can be transient because of these particular in these situations. And then autoimmune thyroiditis, the less than 5% of the cause of autoimmune thyroiditis can be transient, but it's very, very difficult to identify which subset of autoimmune thyroiditis patients will go into remission. So it's if the patient is absolutely requiring very low dose of the drug, 25 micrograms or lesser than that, then we can try to stop. But we have to give very, very clear-cut warning to the patient that you may go into hypothyroidism in the future, and you have to keep checking thyroid function periodically. So this advice we have to give if we are stopping thyroxine in patients with autoimmune thyroiditis, because we never know when they will become hypothyroid again. So that was regarding hypothyroidism. Next, I will go to the next aspect of my talk, thyrotoxicosis. What is thyrotoxicosis? Thyrotoxicosis is increased thyroid hormone levels in the blood, so leading to all the clinical manifestations. So thyrotoxicosis is nothing but increased levels of T3 and T4 in the blood, leading to the clinical signs and symptoms. So now the question comes whether hyperthyroidism and thyrotoxicosis are the same. Is there any difference between hyperthyroidism and thyrotoxicosis, or just two names for the same disease? There is difference. So let me explain you regarding this with the help of a case capsule. So 28-year-old lady comes with a history of weight loss, palpitations, tremors, and sweating since the last 1 month. All toxic symptoms she has, 28-year-old lady. On examination, there is tachycardia. So she has palpitations, she has tachycardia also. There is no goiter or neck tenderness. So she doesn't have any goiter. You can see the biochemical values. Investigation wise, you can see the results here. T3 is on the higher side, 320, normal being 60 to 180. T4, 17.6, normal being 5.5 to 12. And TSH less than 0.01. So this is a clear-cut case of thyrotoxicosis because she has symptoms, she has signs, and biochemical investigations also contributing to the same. So the T3 high, T4 high, suppressed TSH. The diagnosis is thyrotoxicosis. There is no doubt about that. So what about the treatment? So as we learned in our medicine, we have to start carbimazole, right? Shall we start carbimazole in this patient? Yes, it was done. The patient was started on carbimazole, 30 milligram per day. And she returns after 1 month with florid features of hypothyroidism, facial puffiness, weight gain of 8 kgs, edema feet, and TSH was 75. So with carbimazole 30 milligram per day, she became overtly, frankly hypothyroid. So what is the reason? Why did she go into hypothyroidism if she was having thyrotoxicosis? So the reason is she had thyroiditis. It was not hyperthyroidism. So it was just thyrotoxicosis with thyroiditis. So what is thyrotoxicosis? It's a biochemical and physiological manifestations of excessive quantities of thyroid hormones. So the blood levels of thyroid hormones is high. So because of that, the patient is developing signs and symptoms. Then what is hyperthyroidism? This is a tricky, this one here. Hyperthyroidism is thyrotoxicosis only, but here there is excessive synthesis by the gland. So the thyrotoxicosis with excess synthesis within the gland, it's called as hyperthyroidism. So these are the conditions where thyrotoxicosis is not associated with the hyperthyroidism. Subacute thyroiditis, silent thyroiditis, postpartum thyroiditis. Here, because of the inflammation, the excess, whatever storage hormone is there, it is getting released into the circulation. So here there is no excessive production by the gland. So here it's only excessive release. So in other things, thyrotoxicosis factitia, with the patient is taking exogenous thyroid hormones or iatrogenic when we are giving treatment for hypothyroidism. If the dosage is excessive, the patient can go into thyrotoxicosis or ectopic thyroid tissue. So why it is so important? Because all antithyroid drugs, whatever we give, carbimazole, methimazole, propylthiouracil, they will block or inhibit the synthesis of thyroxine. So in patients with thyrotoxicosis, where there is no hyperthyroidism or there is no excessive synthesis, antithyroid drugs are of no use because there will not be excessive synthesis. If you give antithyroid drugs, so it will not do any good, but it will do only harm. The reason is once the patient is coming out from recovering from thyroiditis, once the thyroid gland starts recovering, these antithyroid drugs will inhibit the production. So that is the reason patient will go into very bad hypothyroidism. So that's the reason the differentiating thyrotoxicosis and hyperthyroidism is very important whenever a patient comes and sits in front of us with toxic symptoms and signs and with toxic biochemistry. So definitely antithyroid drugs are not indicated in thyroiditis or thyrotoxicosis without hyperthyroidism, only symptomatic treatment. If there is pain due to decurrence thyroiditis, give pain NSAIDs or steroids. Then if there is palpitations or tachycardia, give beta blockers and just observe them and repeat thyroid function after 6 to 8 weeks. That's all is required. So how to avoid these kind of scenarios, like the patients coming with thyrotoxicosis and we are giving antithyroid drugs and leading to overt hypothyroidism. So whenever there is doubt regarding whether the patient is having hyperthyroidism or not, you have to should not start antithyroid drugs, and if required, you have to ask for technetium scan. So whenever there is doubt like no goiter or no small or very small goiter in patients of hyperthyroidism, majority of the times there will be a goiter. So if there is no goiter or small goiter, the duration of symptoms very short, like lasting for few months, so or with few weeks, then it's very likely that it is thyroiditis. Because in case of hyperthyroidism, the symptoms will last for more than 6 months in many times. So that is the reason short duration of symptoms, no goiter or no feature of Graves like ophthalmopathy or dermopathy, then it's always better to do technetium scan of thyroid. So technetium scan of thyroid will look like this. So this is a technetium scan of thyroid, classical picture of uptake, reduced uptake of thyroiditis. So this is the salivary gland uptake, and in thyroid area, there is no uptake at all. So in the neck, you can see there is no uptake. Technetium scan is not taken up at all. Only when there is hyperthyroidism, whenever there is increased synthesis, the technetium dye or iodine will be taken up excessively and will give increased uptake. In case of thyroiditis, when the synthetic machinery is inhibited temporarily, because of the inflammatory process, there is only release, the technetium or iodine will not be taken up, and there is a reason we'll get this kind of picture of very much reduced uptake. So in such kind of picture, we should never start antithyroid drugs. It is very important because whenever a patient comes with the history of toxic symptoms, signs and toxic biochemistry, so we have to think of this possibility because it's not uncommon. Thyroiditis is very, very common, and in my practice, up to 30% of the patients who come with the toxic biochemistry are having thyroiditis, and they don't require antithyroid drugs at all. So if the patient has hyperthyroidism, excessive synthesis, if the technetium scan also shows increased uptake, these are the causes. So common causes are Graves' disease toxic multinodular goiter and autonomously functioning toxic nodule or toxic adenomas. These are the common causes. Other causes are not very common. Iodine excess, amiodarone-induced, drug-induced, gestational toxicosis, trophoblastic tumors, the TSH secreting adenomas. These are all very rare causes. And the common causes are Graves' disease, toxic MNG, and AFTN or autonomously functioning thyroid nodule. Here, the technetium scan picture will be like this. You can see here diffusely increased uptake in case of hyperthyroidism or Graves' disease. This is a picture of Graves' disease. Increased uptake. You can see a beautiful butterfly-shaped gland. The picture looks beautiful, but for patient it is not that beautiful because the symptoms and signs are very bad. So let me start with a case in one more case scenario. The 50-year-old lady, she has symptoms of toxicosis in the last 4 to 5 months, and she had significant weight loss also. And you can see the staring look. She has diffuse goiter also that is not seen in this photograph. She has moderate, active, inactive ophthalmopathy. Moderate, inactive ophthalmopathy. What do we mean by activity? The clinical signs of inflammation. If the clinical signs of inflammation or activity is present, then we might have to give immunomodulators. I will not go into the details of that. That is altogether a different chapter. So we'll require more time for that. So the biochemistry goes like this: T3 high, 650, T4 very high, 24.6, 5.5 to 12 being normal, and TSH very much suppressed, 0.001. And the diagnosis, Graves' disease with moderate inactive ophthalmopathy. Do we need technetium scan in these patients? It's not mandatory because the patient has clear-cut features like the ophthalmopathy, and she has diffuse goiter, and the symptoms duration is more than 4 to 5 months, then very likely this patient is having Graves' disease. In such scenarios, we need not ask for technetium scan. Only whenever there is a doubt, we are not able to make the diagnosis clinically, then we can ask for technetium scan. So the management here, the antithyroid drugs, the titrating dose of carbimazole, methimazole, or propylthiouracil. So the minimum duration of treatment is for 1 year. So the ophthalmopathy, since it is inactive, there are no signs of inflammation. So there is any active treatment is not required. Why should we go for medical management in such patients? Why can't we go for surgery or radioiodine therapy? Because the medical management is the only form of therapy correcting the basic pathology. What is the basic pathology? It is a TSH receptor antibodies, the TSH receptor stimulating antibodies, which stimulate the TSH receptor to produce more and more T4 and T3. So these antibody levels will come down once we start antithyroid drugs. So that is the reason it is the only form of therapy correcting the basic pathology. Chance of complete cure without hypothyroidism is much higher compared to surgery or radioiodine therapy, and it is the only treatment when the T4 levels are very high. When the T4 levels are like very high, such the T4 like in this patient 24, we can't subject them for iodine therapy or surgery because it is risky. The patient can go into toxic storm or crisis. So that is the reason we have to give antithyroid drugs. What are the drugs available? Thionamides like carbimazole, methimazole, or propylthiouracil. Then in case of emergency management, we can go for iodides, and when we can't give antithyroid drugs, we can think of lithium also as one of the management armamentarium. So as I was telling you, the Graves' disease pathophysiology is because of this TSH receptor stimulating antibody coming and binding with the TSH receptor. So the TSH receptor antibody mimics TSH. It will stimulate the TSH receptor to produce more and more thyroxine. So the thyroxine overproduction will be there. So overproduction of thyroxine as well as triiodothyronine because of the stimulation by TSH receptor. Right? So that can lead to intrathyroidal iodine deficiency. That's how it works. So large dose of PTU impair the conversion of T4 to T3, and thyramides also have direct influence on the immune response, and that's how they reduce the TSH receptor antibody levels. Half-life of carbimazole is approximately 6 hours, and PTU is 1.5 hours. And single dose of carbimazole may exert an antithyroid drug effect for more than 24 hours. So that is the reason, since the drugs are accumulated actively by the thyroid gland, the antithyroid drugs like carbimazole or methimazole can be given once daily. Both carbimazole and PTU cross the placenta, but PTU crosses to a lesser extent. So that is the reason, in case of pregnancy, especially the first trimester, since the teratogenicity is lesser, the PTU is preferred over carbimazole in first trimester of pregnancy. So these are the adverse effects. Common adverse effects are rashes, urticaria, fever, and arthralgia. It's seen in up to 1 to 5% of the patients. Rare serious adverse events like hepatitis, SLE-like syndrome, or agranulocytosis can happen. It's seen in less than 1% of the patients. So, which antithyroid drug is superior? So, there is no doubt carbimazole or methimazole, both are same actually. Carbimazole is a prodrug of methimazole, so the dose requirement will be slightly lesser for methimazole. Otherwise, there is no difference. Compared to propylthiouracil, the carbimazole is better in many aspects. Like carbimazole can be used once daily and much cheaper, and reactions are much lesser and less serious, and rapid normalization of T4 is seen with carbimazole, and less effects for further radioactive iodine treatment. And propylthiouracil also has one of the major issues. It can lead to fulminant hepatic failure. So that is the reason it is not commonly used. PTU, propylthiouracil, is not commonly used because of the adverse event of fulminant hepatic failure. So that is the reason it is contraindicated in children. It's banned for usage in children. Children with Graves' disease or toxicosis, we have to use carbimazole or methimazole. So the advantage of propylthiouracil is in pregnancy, because the first trimester the placental cross is lesser, passage is lesser, and teratogenicity is lesser. Toxic crisis, because of when high doses when we use, the conversion of T4 to T3 can be inhibited. So that is the reason PTU is preferred in toxic crisis with higher dosage. So management of Graves' disease, I will not go into the detail. We can start with the higher dosage and then we can come down. So give beta blockers also, because it gives relief from adrenergic symptoms, and therapeutic response usually occurs after a related period of 6 to 8 weeks. Follow-up usually we can clinically there will be improvement in 3 weeks, but by 4 to 6 weeks the T3 T4 levels improve. The TSH we should never ask in the initial phase, like initial 4 to 6 weeks. The TSH will never normalize. It will take time. So that is the reason we have to ask for T4 levels or T3 T4 levels initially. Then dosage slowly step down or up depending on the T3 to T4 levels initially. And finally, once the TSH is normalized, usually after 3 to 6 months, then we can monitor, or dosage titration can be done based on TSH levels. So treatment should be continued for at least 6 months after TSH normalization, and usual duration of treatment is 12 to 24 months. So many studies have clearly shown that if we give antithyroid drugs for a period of 12 to 24 months, the chance of remission is much higher compared to the less than 6 months of therapy. So relapse, we can go for iodine therapy or surgery, thyroidectomy. If the patient relapses with the antithyroid drugs, we can go for definitive management like radioiodine therapy or surgery. So what are the indications for surgery? So like relapse after antithyroid drugs with the large goiter, presence of large goiter, and severe Graves' ophthalmopathy, pregnancy if antithyroid drugs fail, then Graves' disease with cold nodules, and not willing for radioiodine therapy. These are the indications for surgery. And some indications like social indications in a like unmarried girl when getting married after 6 months or 1 year, so they don't want to take the risk of continuing antithyroid drugs. Definitely we can think of surgery as an option. So concluding my talk, the hypothyroidism is early diagnosis is very important, because then we can give quality of life to the patient. Proper monitoring is important. So if we do properly monitor and properly titrate the dosage, we can do monitoring once in a year. It's a very easily treatable condition. So that is the reason in whenever there is slightest suspicion, we have to ask for thyroid hormone levels. Thyrotoxicosis always should be differentiated from hyperthyroidism, because in thyrotoxicosis without hyperthyroidism, conditions like thyroiditis, antithyroid drugs are not at all indicated, and they'll do more harm than good. So the medical management like antithyroid drugs should be tried in at least 1 year, for 1 year in patients with Graves' disease, because we can give medicine-free lifespan for majority of these patients. Not majority, at least 50% of these patients.
Any members having any doubts can ask.
Chat box, shall we?
Yes, sir. A chat box.
Nothing, no?
No, I think most of them are high. As per my knowledge, most of them had doubt between this hyperthyroidism and thyrotoxicosis, sir. So that
Okay.
made very clear. And
I think there are some questions in the chat box. Shall we go through that,
yes,
Kishan?
sir. Yes, sir.
How to start levothyroxine in pregnancy? So that was the one question. So levothyroxine in pregnancy, when we have like look at the TSH, if the TSH is between 4 to 10, you can start with a lower dosage, 50 micrograms. Otherwise, if the TSH is more than 10, you have to go for a higher dosage. Usually 2.4 microgram per kg body weight, that is a requirement. You can minimum dosage requirement is 100 micrograms in overt hypothyroidism. Next question, how ectopic ACTH production occurs in neuroblastoma? So neuroblastoma actually, so there will be ACTH product producing like corticotropes. So there will be the expression of these corticotropes in these neuroblastoma cells. So that is the reason ACTH production can happen. So ectopic ACTH production can happen in the bronchial carcinoids, thymic carcinoids, pancreatic neuroendocrine tumors, neuroblastomas. All these because of the ectopic expression of these corticotropes, the ACTH production happens. Why hypertension is more common in the ectopic ACTH syndrome than in other forms of Cushing? So here actually the hypertension is more common because the metabolic abnormalities are more common in ectopic. The production of ACTH is much higher in case of ectopic ACTH compared to the ACTH produced by the pituitary adenoma. So that is the reason the ACTH secreting pituitary adenomas, they evolve slowly. So Cushing's disease takes many years to evolve. Whereas ectopic ACTH secretion, especially the small cell carcinoma, they usually will not have overt Cushingoid features. They might present only with hypokalemia or hypertension. So that the reason is there is no enough time to develop all the Cushingoid features. So it's very rapid because of the high levels of ACTH. So that is the reason the hypertension is much more common in ectopic ACTH, and hypokalemia is also much more common in ectopic ACTH syndrome. So how long does it normally take for subclinical hypothyroidism to develop into hypothyroidism proper? On patient antipsychotics, I noticed it keeps changing. So I agree. So especially the lithium is known to produce. Even otherwise, there can be some variation whenever they are on antipsychotics. Subclinical hypothyroidism, progression to overt hypothyroidism, it takes a varied amount of time. So it was seen that according to the prospective studies, every year, 5% of the patients will progress into hypothyroidism. Every year, 5% of the subclinical hypothyroidism will progress into hypothyroidism. But for an individual patient, it's very, very difficult to say how long it will take. Some people will remain in the subclinical hypothyroidism range for their lifetime. So that is the reason we have to keep checking. And if there are indications like goiter, anti-TPO antibody positive in high titers, then we have to start thyroxine. Otherwise, we can just observe.
In YouTube, there is a doubt, sir. How to treat postpartum thyrotoxicosis, which is not hyperthyroidism.
So postpartum thyrotoxicosis is nothing but it's a thyroiditis only. So there is excessive release of hormones from the gland because of the inflammation in the postpartum state. So they require only symptomatic management. If there is significant palpitation, we can give beta blockers, and majority of the times they don't require any treatment. We have to just reassure them that it is a transient phase and it will become normal. And when you are asking after 2 months, you have to repeat the thyroid function. And when you are repeating, please ask for anti-TPO antibody also, because majority of the times these postpartum thyroiditis will be like Hashimoto's. Anti-TPO antibodies are present. It's a Hashimoto's thyroiditis, will presenting initially as thyrotoxicosis. So later they'll go into overt hypothyroidism. Many of them will go in when the next time after the 2 months or 3 months when they come, the TSH will be more than 100. So they rapidly progress into overt hypothyroidism. So if the anti-TPO antibody levels are very high and the TSH is also high, then it's better to start thyroxine in such categories of patients.
And what is the criteria to stop thyroxine medication, sir? For how long it should be normal, or when to stop?
Yeah, actually, thyroxine in autoimmune hypothyroidism, and the TSH anti-TPO antibody titers are very high, when the requirement is more than 50 micrograms, it's better not to stop, because there are two reasons. One thing, majority of them will require lifelong medication. Once we stop, the TSH will jump again.
Yeah.
So, but in subset of patients, when the thyroxine requirement is less, like less than 25 microgram per day, then you can stop, try to stop, but you have to tell them clearly that the follow-up is mandatory and they have to come after 3 months or 6 months, at least one year, because the TSH can go up. So the low requirement, anti-TPO antibody, either negative or positive in low titers, like upper range of anti-TPO, let us say it is 16, the anti-TPO is only 20 or 25, then you can try to stop if the requirement is less.
And post-thyroidectomy, it's a must to take a lifelong supplementation, sir. No other way out.
Absolutely, but in case of hemithyroidectomy, if the patient is
total thyroidectomy.
Total thyroidectomy, yes. So they have to, because there is no way out unless the surgeon is liberal enough to keep some good amount of thyroid tissue back. Otherwise,
not liberal enough, sir. Afraid enough to incur recurrent laryngeal nerve.
Correct.
Or parathyroids.
Correct. So I think one more question, Kishan. How neuroendocrine cervical carcinoma occurs in multiple endocrine neoplasia type 4? So neuroendocrine carcinoma, neuroendocrine tumors can develop anywhere in the wherever there is chromatin cells which are entering there, neuroendocrine tumors can develop. So that is the reason in type 4 MEN cervical carcinoma can happen. So neuroendocrine tumors it can happen anywhere in the body.
Sir, how about Graves' disease with cold nodule? They are asking.
Okay, so that's an important question. It's a Mean-Lenhardt syndrome, the Graves' disease with cold nodule. So whenever we do the Graves' disease with cold nodule will be noticed only by radioiodine uptake scan or technetium scan. So whenever we do technetium scan, if there is a cold nodule like a diffuse uptake, one particular area not taking up, then definitely we have to go for FNAC, fine needle aspiration cytology of that particular nodule, because they are known to have some amount of malignant tissues inside. So the malignancy is much more common in Graves' disease with cold nodule. So that's why FNAC is a must. If FNAC shows any malignant feature or suspicious of malignancy, then definitely the patient should be subjected for total thyroidectomy.
So what is the importance of newly detected hypothyroidism with raised levels of antibodies?
Newly detected hypothyroidism with raised levels of antibodies suggests that it is Hashimoto's thyroiditis or autoimmune thyroiditis with primary hypothyroidism. Then two things we have to emphasize to the patient. One thing, the thyroxine is a must. Thyroxine you have to take. Your body doesn't produce enough thyroxine. So that is the reason you have to take, and how to take, all those things we have to explain. Second thing, we have to emphasize that this will be lifelong, because the anti-TPO antibodies are positive in high titers. So very unlikely that your gland will start functioning again. So you have to take lifelong. These 2 points we have to emphasize to the patient.
How to decrease the dose of thyroxine when the TSH levels comes down?
Okay, so if the TSH level lies within the normal limits, let us say the 0.5 to 3. So that is the target we keep whenever we treat hypothyroidism, 0.5 to 3 micro international unit per ml. So if it is in that range, no need to reduce the dosage. You keep the same dosage. If you keep on reducing the dosage, next time the patient will come with a higher TSH. So only if the patient's TSH goes below 0.5, then you have to reduce. Let us say we have started with 100 micrograms of thyroxine. The next time the patient comes with a TSH of 0.1. So it is an indication to reduce. You reduce the dose by 25 micrograms. So from 100, you come down to 75. So don't reduce it to 50 or 25 micrograms. That will not be sufficient at all. The patient will come back with the TSH, very high TSH next time. So reduce the dose to 75 and call him after 3 months. And at that time, you ask for TSH again. Again, if the TSH is 0.2 or 0.1, reduce again by 25, make it 50, like that.